You. Welcome, dear friend, to the European Society of Gynecology webinar. As you know, this afternoon we will have two fantastic speakers, Professor Blazej Meczekalski from the University of Poznan in Poland, and Professor Alessandro Genazzani from the University of Modena. And the webinar is ready to start. At the end, you will have the question and answer. Please write your question in the question and answer, and then I will read them to our speakers. In the next slide, this webinar will be live captioned, and we have the topic is the contemporary view on functional hypothalamic amenorrhea. Next slide. Thank you. Okay, this will be next. And the first speaker will be Professor Blazej Meczekalski. Dear Blazej, if you have your presentation, you can join us on the screen and share the presentation. Ecco. The title of Professor Meczekalski is Pathophysiology and Long-Term Consequence of Functional Hypothalamic Amenorrhea. Blazej Meczekalski is Professor of Gynecological Endocrinology and the Chairman of the Department of Gynecological Endocrinology at Poznan University of Medical Science in Poland. He is also member of the board of the European Menopause and Andropause Society, of the European Society of Gynecology, and also of the International Society of Gynecological Endocrinology. He is absolutely well recognized as not only speaker and chairman, but scientist. And if you go on PubMed and you put Meczekalski B, you will see the beautiful production that he have done. And how many papers they're focusing just on that topic, on pathophysiology and long-term consequences on functional hypothalamic amenorrhea. Blazej, you have the microphone.
Thank you very much, Professor Genazzani, for kind introduction. It's a pleasure to present this topic. We can start because the topic is related to neuroendocrinology. And we can say that before the 70s of the past century, we could not talk about pathophysiology, diagnosis, and treatment of functional hypothalamic amenorrhea because our knowledge was not sufficient. Only the big revolution took place in the end of 60s or the beginning of 70s when these two important scientists independently worked on different neuropeptides and neurohormones. They identified in 1971 gonadotropin-releasing hormone, in other words, gonadoliberin, as the key neurohormone for reproduction. And starting from this time, we can completely better recognize the problem of the pathophysiology, diagnosis, and treatment of different disorders at the level of the hypothalamus. GnRH is a simple substance. Why? Because it is composed of only 10 amino acids. It's decapeptide. And this is one point. And second point is that it is secreted in the specific manner. It means in the pulsatile manner. In the first phase of the menstrual cycle, pulses occurs physiologically every 60 to 90 minutes. This pulsatility is characterized by specific amplitude and frequency. And you can see, I cannot describe everything during my short presentation because GnRH is secreted as the GnRH pulse generator, but apart from it, due to different feedbacks and relation, it can be regulated even through the feedback system or impact of other neuropeptides from the level of hypothalamus, and also the impact of substances from the periphery, like ghrelin from the stomach, leptin from the fat tissue, also thyroid glands, and insulin. And now I will focus on neurocrine determinants of functional hypothalamic amenorrhea. What is functional hypothalamic amenorrhea? We can say that it is reversible disarrangement of GnRH pulsatility. You can see on these quite old figures, 20 years old, but still very representative, the gonadotropin secretion in the prepuberty time during adulthood, typical gonadotropin pulsatility, and in the case of hypothalamic amenorrhea, you can see how is this arrangement. And here you can compare, because also in professional athletes, the hypothalamic amenorrhea is important problem. It can occur approximately in 50% of these athletes. You can see in cyclic athletes, the LH pulsatility is still preserved, but in amenorrheic athletes, you can see what is the disarrangement of LH and also, of course, GnRH pulsatility in the sense of the peaks or surges, and also in the sense of frequency. And of course, if you look from this publication, it can be different background or different disturbances of pulsatility. The dominant is the lower frequency of LH pulses, but also can be the apulsatility or changes in the amplitude, low amplitude of the LH, in other words, also GnRH. And we can distinguish generally three types of functional hypothalamic amenorrhea. It can be related to stress, to excessive exercise, and to severe weight loss. This problem is, you can see that this clinical problem is really related to the stress impact, starvation, and also excessive exercise, which can be understood as the type of the stress. And this gentleman, Hans Selye, a Hungarian Canadian origin, he was the first who put such important attention and also work, 50 years of work, to understand the stress and its important impact on the hormonal function. He was the first who found that the hypothalamic pituitary adrenal axis is the main mechanism responsible for the stress response. And we know that this important interplay between stress axis, CRH, ACTH, cortisol, and reproductive action, GnRH, FSH, LH, and estrogens. And many publications from the last 15 or 20th century proved there is the hyperactivity of hypothalamic pituitary adrenal axis. You can see generally the increase of CRH, ACTH, and for many years the point was that CRH can directly inhibit GnRH pulsatility, and it can be understood as the cause of stress-related functional hypothalamic amenorrhea. CRH is another important neurohormone. It was discovered exactly 10 years after GnRH, but by this gentleman from Salk Institute, Wiley Whale. And apart from the stress, it can play also a role in other listed here important processes. It was found that total cortisol is increasing the circulation and also in cerebral spinal fluid in patient also with anorexia nervosa and depression. And during my stay in Pisa, more than 25 years ago, we, together with Professor Genazzani, Andrea Genazzani, we made the study, evaluation the patient with functional hypothalamic amenorrhea. We evaluated the stress response, and we found that mean serum ACTH response to CRH was decreased, and similarly, mean serum cortisol response to CRH in this group of the patient was also decreased. And here is the typical graph which can describe how a graph from more than 25 years ago by famous scientist from Greece, Professor George Chrouzos. You can see the dotted line when CRH can directly inhibit CRH secretion or can stimulate beta endorphin, and in turn beta endorphin can inhibit GnRH secretion. But our knowledge is still broadening, and we can observe now, after discovery of another important peptide, which name is kisspeptin, that according to the present knowledge, there is no direct impact of the inhibition CRH on the GnRH pulsatile secretion, but kisspeptin neurons, because CRH receptors are expressed in the kisspeptin neurons, kisspeptin neurons can play a role as a kind of the mediator between CRH, in other words, stress, and impact on the GnRH, it means on the reproduction. It is very well visible on this graph. And you can see how important is the impact of the stress on different peptides, neuropeptides, neurotransmitters. You can see, for instance, in the stress circumferences, kisspeptin is decreased, but other hormones like oxytocin, relaxin, nesfatin is increased. Another important, maybe not such strictly related with the stress, but more with the food intake peptide is neuropeptide Y, discovered in 1982. It plays very broad role also in the regulation of the GnRH secretion, but also regulation of the food intake. And together, also quite time ago, we, together with Professor Alessandro Genazzani, tried to evaluate NPY and LH concentration and pulses in patients with functional hypothalamic amenorrhea. And you can see here, we found that NPA concentration are lower in this group of patients than in controls, and NPY peaks number is higher in this group of patients than controls. And now a few words about very important peptide, which was discovered, identified at the beginning of this century, but the gene was discovered in 1996. The name is kisspeptin. You can see where it's expressed and where it's secreted. Mainly it's secreted in the hypothalamus, in the arcuate nucleus and antroventral periventricular nucleus. And kisspeptin play the critical role for the regulation, positive regulation of GnRH secretion. Also, it is an anatomical proximity between kisspeptin neurons and GnRH neurons. We can it was identified that kisspeptin receptors are expressed in the GnRH neurons, and therefore kisspeptin can directly has an impact on the GnRH release and GnRH pulsatility. Also here you can see, using this quite good feature from 2013, how profound is impact of different stimuli or different action like metabolic stress action through different described here peptides on Kindi neurons. What are Kindi neurons? Kindi neurons are expression of three different neurons together. Ki is kispeptin and neurokinin B, and D is dynorphin. They are now regarded as the GnRH pulse generator because you can see, please look on this graph, through the different signals goes through Kindi neurons, and in turn Kindi neurons can regulate or modulate the GnRH secretion. And kispeptin is generally important for activation of hypothalamic pituitary ovarian axis, also during puberty initiation, regulation of menstrual cycle, and ovulation. And apart from regulation of the GnRH secretion through the positive feedback, kispeptin neurons are responsible for the surge as a surge generator. And together with Professor Alessandro Genazzani in 2016, we tried to publish paper in fertility and sterility because we tried to evaluate the secretion of kispeptin and LH in healthy women. The question, the aim of the study was to evaluate what is the secretion of these two hormones and if there is the copulsatility of these hormones, kispeptin and LH. And after the great analysis of Alessandro, informatic analysis, we showed for the first time that kispeptin and LH are co-secreted and the temporal time 0 and the peaks occur at the same time point. The similar project, the similar methodology was used also, but not in healthy patient, but in patient with functional hypothalamic amenorrhea. It was published 4 years later, and we divided the group of patient, quite big group of the patient with FHA, for patient with hypo-LH and normal LH, and we found that patient with a hypo-LH, low level of LH, are characterized by significantly lower kispeptin levels, also LH, than normal LH patients. And also, just 2.5 years ago, we tried to evaluate another important peptide, neurokinin B, in our department in patients with functional hypothalamic amenorrhea, and we found that mean serum NKB levels were significantly lower in hypothalamic patients in comparison to healthy and normally menstruating women. Considering the diagnosis shortly, we know how important is the proper diagnosis. In my opinion, medical history has a crucial aspect because it's very important to talk with the patient or parents or mother of this patient and figure out what is the main problem and main stimuli which can be responsible for functional hypothalamic amenorrhea. Also examination, ultrasound, endocrinological investigation, and densitometry is important. The typical hormonal profile is characterized by a low level of FSH, even lower than FSH, low level of LH, and very low level of estradiol. It means this patient are characterized by hypogonadotropic hypogonadism and hypoestrogenism. And of course, different hormones, according to the Endocrine Society guideline, should be evaluated. I also mentioned about the role of the evaluation role of bone mineral density to evaluate in amenorrheic patient with secondary amenorrhea longer than 6 months due to hypoestrogenism, and just to remember about what should be the differential diagnosis with PCOS, hypothyroidism, of hyperprolactinemia. And now the last part of my presentation, because we should be aware that functional hypothalamic amenorrhea is, of course, amenorrhea, secondary amenorrhea. It means that is the inhibition of the reproductive function. But the point is that it is not only from the clinical point of view, it's not only the reproductive problem. It's a very broad problem. The hypoestrogenism in this patient has negative impact on almost on the whole body of these young women. You can see that it can have the negative impact on the function of central nervous system, the impact on the concentration, memory, the mood disorders, the cognitive function, the impact on the cardiovascular system, mainly through the impaired endothelial function, but also the consequence of mainly hypoestrogenism can be the atherogenic lipid profile, the impact on the skin, and as I mentioned previously, important negative impact on the bones in the sense of the decrease of the peak bone mass and also the decrease of the bone mass density in the direction of osteopenia or osteoporosis and increased fracture risk. The point is that you can see which factors can be responsible for the peak bone mass. But the point is that if we have hypoestrogenism or functional hypothalamic amenorrhea in the young women, they cannot achieve the optimal peak bone mass. Therefore, they are more threatened by osteopenia and osteoporosis, and the fracture risk is increased because the peak bone mass is formed in more or less almost in 50% during adolescence time. The main mechanism of positive impact of estrogens is related to the inhibition of bone resorption. Of course, the positive impact of estrogens can be visible only above kind of the threshold. It means more or less more than 40 or 50 picograms per ml. And these are the factors, real factors responsible for BMD decrease in this group of the patient. I mentioned hypoestrogenism. The patient are characterized by hypercortisolemia, decrease of IGF-1, decrease of calcium vitamin D3, decrease of osteoprotegerine. These are the same, almost the same factors, but from the other publication. Here is the proof that this patient by Klibański, old publication, but very good, that this patient are characterized by decrease of bone mass density. Our publication more than 10 years ago. Also, we prove that patients are characterized by decrease not only lumbar spine bone mineral density, but total bone mineral density. The important point is also the female athlete triad. What does it mean? I previously mentioned about sportsmen or professional athletes. We can distinguish three important points. They can suffer from eating disorders, amenorrhea, hypothalamic amenorrhea, and osteoporosis, particularly runners, ballet artists, dancers, and gymnasts. And energy availability is something we can express as the energy remaining for all physiological function after exercise. If it is very low, it can have negative impact on the all organs. And apart from the female athlete triad, the new definition, more broad, it was developed in the United States, is relative energy deficiency in sports. It includes not only female athlete triad, but please look how many different systems can be impaired in this group of the patient. I just mentioned that in this group of the patient, after 6 months of hypoestrogenism, is the indication to perform the densitometry exam. And the point is also that bone mass loss is related with the age of the hypoestrogenism, in which age it occurs, how long it occurs, let's say 6 months or 2 years, and severity of the disorders. In other words, what is the level of estradiol. Different impact will be with the estradiol level 5 picogram per ml and different with 35 picograms per ml. And gaining the appropriate peak bone mass is kind of our prevention against osteopenia and osteoporosis. At the end, I'm putting your attention also on the impact, negative impact of hypoestrogenism in this group of the patient on the cardiovascular system due to listed here different mechanisms. And here is quite new publication from JCM 2023. They found that approximately 30% of patients with functional hypothalamic amenorrhea presented endothelial dysfunction. And also good publication about the disarrangement of mood and sexual function by group of Professor Rosella Nappi. They found that these patients are characterized by more sexual dysfunction, higher depression, and anxiety. Similarly, in this publication published 3 years ago. And in the end, I think that not only pathophysiology is important to know, but also the long-term consequences of functional hypothalamic amenorrhea, which I described. Thank you very much.
Thank you very much, Blazej, for that beautiful lecture, who focus on the importance that we have to take related to functional hypothalamic amenorrhea. Functional hypothalamic amenorrhea really express the central disorder of the woman when the stressful stimuli, eating disorder, excessive training are touching her. And then I would like now to thank you very much, and then we would like to move to the second presentation of this webinar. Then Alessandro, done by Professor Alessandro Genazzani. Alessandro, can you share your screen? And
sure,
thank you.
Here I am.
Okay, we are coming. Okay.
Just a while, just to have hopefully.
Then, in the meantime, Professor Alessandro Genazzani is professor of gynecological endocrinology at University of Modena, and is also the president of the Italian Association of Gynecological Endocrinology. Is member of the board of many societies involved in this area, starting from the Endocrine Society, but also is a member of the board of the European Society of Gynecology. And also for Alessandro Genazzani, if you go on PubMed, you put Genazzani AD, you will find how many papers and study have done, and a huge series related to the functional hypothalamic amenorrhea, and specifically on complementary treatment and low doses estrogen as treatment for functional hypothalamic amenorrhea. Thank you, Alessandro. You have the microphone. I suggest to everybody to write your question related to Professor Meczekalski presentation and to Professor Genazzani presentation, and we will discuss all of them at the end of Alessandro's presentation. Please, sorry, go on.
Thank you, Andrea, and also thank you to Biagio for a so delightful presentation, since to understand better how to manage these patients that are quite complicated, you need really to have clear ideas on how the neuroendocrine connection work. Well, it's clear that stress is at the basis of the functional hypothalamic amenorrhea. And mainly, you know very well, this is a combination of three main stressors, such as the one due to physical activity, the lack of food, or the excess of energy consumption, and also psychological stress. Remember that stress is an adaptive situation, something that is classically inside our biology, and is a system that permits and permitted to us to survive in these last 2.5 millions of years of evolution of the mankind. Well, one of the topic of the problem of being stress so negative in our biology and in reproduction is the lack of food, or the minimal amount of food just to survive and then to reproduce. Since the beginning, we have been hunting animals, and only recently we have learned how to manage the combination of proteins together with vegetables and the derivatives of grains. And this means that in these last 10,000 years, our way of facing and having food has been changing a lot. Well, if we check the pyramids of our nutrition, you see that we have moved from a very specific one with a lot of proteins because we were hunting, to another one which is typical of the modern times, where proteins are very reduced in amounts and a lot of complex carbohydrates are represented. But now things are changing. Well, fortunately, in these last 12 months, someone have really greatly demonstrated that the lack of proteins and the excess of carbohydrates are negative. And so this is the new pyramid, completely the opposite of the one that we have been having up to now. But when dealing with the stress and knowing what kind of stressors we might have, we have always to remember that there are two situations, the chronic and the acute one. The acute one is just a random chance of being stressed, so nothing that can change the way of working of our biology. On the contrary, the chronic one is a persistent condition where the biology needs to face and to find a solution just to overcome the negative impact of stress and in all the damages that this might induce. Always, we have to remember that mankind today is not different from the old one of 2.5 millions of years ago, but the stressors are relatively different. We do not have to hunt. We do not have to run because some wild animal is running after us, but probably we have a lot of other stressors, such as the familiar problems, the working problems, probably family problems, and also the stressors are related to the fact that women are more than men, obviously, taking care of the shape and of the body weight. And so all these are able to create problems in our biology in terms of reproduction. And typically, we lose the menstruations, but mainly we change the endocrine profile, classically related to the release of gonadotropins. And as we have already heard from Professor Meczekalski, we have clearly inside the hypothalamic hypophyseal regions a change, a great change in the neuromodulators and the neurotransmitters that permit the epiphysis to work well, so that the gonadotropins change their way of being secreted, not only in terms of pulsatility, as you can see here, very low, very small and tiny peaks, but also in terms of the amounts of gonadotropins. Well, the messages are coming from the periphery as well as from the brain, and we have clear idea that as someone told in the early 18th century, professor and the philosopher Feuerbach was saying, man is just what he is eating. This means that the messages coming from the gut, from the intestine, from the fat, from the muscles, are messages that are greatly interpreted and considered by the hypothalamus. So the messages due to the leptin, insulin, ghrelin, cholecystokinin, and why not, GLP-1 substances are able to modulate the response in terms of reproduction and the adaptation to such messages by the hypothalamus. Also, the brain-derived neurotropic factor, a quite relevant neurohormones that is able to modulate and permit a good surviving of the astroglia and the astrocytes as well as of neurons, is tightly dependent of all the equilibrium due not only to the gonadal steroids, but mainly to the neurotransmitters informing the hypothalamus of the good situations or to the bad situations. Whenever we have, obviously, stressant situation, brain-derived neurotropic factor is reduced. And we have to remember that metabolism is affecting our biology and also in other ways. The reactive oxygen substances are the classical product of the excess of oxidation of substances such as carbohydrates, but also due to the excessive metabolism stressors that are typically hyperactivated and produced by patients with functional hypothalamic amenorrhea, especially if they are physical active in a greater way. Think a little bit to the athletes or to the dancers. This means that we have a lot of substances that are negative for our biology going all around our blood and affecting the functions of all the organs where such substances are. So it comes clear that we have specific conditions of disequilibrium between what is coming from the physiology of nutrition and of metabolism with what are the consequences of such effects on the neuroendocrine systems. So deficit of glucose and a quite a normal way of having food is creating conditions of reduction of insulin, excess of glucagon, and mainly excess of cortisol due to the relative amount of good things eaten by these patients. And this is conditions that create, adaptation also of other glands that are not really involved in reproduction, but are greatly relevant for the equilibrium of metabolism and mainly to try to save energy for additional bad times. And this is the thyroid. And you see that we have the reduction of the free T3 hormone. And this is the classic signal and evidence of the so-called low T3 syndrome, typical of patients with functional hypothalamic amenorrhea and very low reduced storage of energies. So just to give a clear idea, the equilibrium between the good health and reproduction is a match between two situations, which are the response to stress and on the other side, the response to the stress due to what kind of feeding and metabolism we have. And all these are able to affect the reproductive system, because there is a simple solution to this, not to spend the energy in something that might be dangerous for the biology of that girl. Since whenever you have a pregnant woman, the amount of energy that are needed to permit the pregnancy to go from the day first to the last day of the 40th week of pregnancy are millions of calories. Consider that a pregnancy required in between 4 up to 5 million calories just to be completed. And you can survive every day with just 1,200 calories, which are completely a reduced number of energies in comparison to the pregnancy. So you can understand how our biology, which is coming from 2.5 million of evolution, is taking care of life and surviving and health of a young girl who is deeply stressed and mainly probably consuming or not getting too much energy with the food. So the results is the blunting of the pulsatility of LH, the reduction of the response of the ovary. So we do not have any recruitment of follicles and no, obviously, ovulation. But what have we to do with these patients? Before thinking on what kind of treatment we might use and propose, we have always to check the anamnestic conditions and situations. And remember that sometimes we probably do not have to believe to the women according to what they are saying, especially if they are very lean or they have a very reduced BMI, because this means that feeding and physical activity probably is tightly and greatly affecting these patients. And do not believe that functional hypothalamic amenorrhea is just something occurring in the young girls, because you see, this is a study quite old, but it has been the clear demonstration that all along fertile life, you might have a functional hypothalamic amenorrhea. You can see how the part of the cake that you can see in this cartoon is quite high independently from the age. You are young, below 20 years, or you are older but fertile, up to 40 years of age. So the problem is the combination of the stressors and the response inside the brain, inside the hypothalamus, affecting the release of GnRH. This is something that Professor Meczekalski have already told us, but this is not an organic disease. This is a physiopathological response that corresponds exactly to a specific defending system for these patients. And remember that we have two opposite situations creating amenorrhea and so, let's say, infertility. The excess and the defect in the body weight. And astonishingly, well, the excess of food on one side or the excess of not food on the other one are able to modulate and negatively stimulate the function of the hypothalamic pituitary areas. And this is quite clear because also in the excess of body weight, there are the biology have the perception of negative situations that might occur in case of pregnancy. So it can be clear stated here that the driver of everything is insulin. And as you can see in this cartoon that comes from the paper that we published a few years ago, insulin is the driver in the excess for PCOS patients or overweight, obese patients, as well as in functional hypothalamic amenorrhea, where insulin is very low. And insulin, in any cases, is able to stimulate very low or too much the neurons of kisspeptin inside the hypothalamus. And then you have the cascade of high level of LH in PCOS, and with very low stimulation of LH, mainly due to low kisspeptin and to low insulin, as Professor Meczekalski have greatly demonstrated to us, you have the classic situations of low levels of LH in functional hypothalamic amenorrhea. So kisspeptin is the key factor, together with others. Obviously, everything is perfectly in equilibrium, but kisspeptin is the driver of all such conditions because kisspeptin is released by KNDy neurons in these two areas of the hypothalamus, so inside the antroventral periventricular nucleus and in the nucleus arcuate. But these two groups of neurons are differently sensitive to estrogens. And this is the beginning of something which will be disclosed later, but keep this in mind, because in the AVPV nucleus, you have the play of the positive feedback, while in the ARC nucleus, where you have the other KNDy neurons, you have the playing of the negative feedback due to estrogens. And in the same interneurons affecting KNDy neurons, there is the play of insulin and GH-renin and leptin. So you see, everything is played there. Everything is greatly conditioning reproduction, just a mixture of such kind of signals. We have spent a lot of time working on functional hypothalamic amenorrhea because we tried to see if we might understand better the disease and find what was or what might be the best solution to propose to the patients. So you see clear that we have tried to disclose what are the role of opioids, of GABA, of serotonin, dopamine, of cortisol, prolactin, of thyroid hormones, and mainly, we tried to understand that we might face the problem of functional hypothalamic amenorrhea affecting such disease using, on one side, real pharmacological treatment, but we probably might try to use some integrative compounds that are able to be, how do you say, the oil inside the engine of this car, which is not really properly working. But at the basis of everything, especially in functional hypothalamic amenorrhea, is always present the fact that you need to have a good quality of nutrition. You need good quality of food. More than quantity is not a matter of having a large plate of spaghetti. You need to have a great, good, regular plate of nutrients that are able to give you energy, yes, substance, yes, and structure to permit the biology to work and to maintain your body. So the integrative approach that we have for many years evaluated and considered is the one using carnitine. Carnitine is something which is coming from the degradation of proteins, from the degradation of amino acids, and mainly from the proteins, not from the vegetables, but mainly from the proteins of animals, such as the cows. And it's relevant to say that carnitines means coming from the meat. And this has been clearly demonstrated since a strict vegetarian diet created deficiency of carnitine in these patients. And carnitine is the driver of a lot of substances and a lot of induction inside the central nervous system. And where is carnitine coming from? From lysine, which is an amino acid, which is typically, absolutely typically, as a degraded amino acid from protein from the red meat. So good health means that you have to eat well. And the good thing is that all the amino acids are essential, but mainly is lysine, the good ones that is needed. And you can see here that carnitine has a relevant role when you have to use free fat acids and to transform them in energy, especially inside the brain, for the neurons, for the astrocytes. And all such lack, if you do not eat meat, means that the system is not properly working, especially the hypothalamic areas. So we started many, many years ago. Andrea remembers well such kind of work that we published in 1991, so 1,000 years ago, where we supplemented the patients with functional hypothalamic amenorrhea with L-acetylcarnitine. And as you can see here, just look at the panel on the right, the pulses of LH from very small and tiny became with a greater amplitude, with a similar frequency, but they were able to stimulate the ovary. So we started again to see estradiol rising in the blood. And then after a couple of months or 3 months at least of integration, we got the presence of the first menstruation. But these studies were just the beginning of the story, since we tried to understand where such kind of supplementation was able to modulate and to act. So we tried and tested the naloxone infusion test in these patients before and after such kind of supplementation. And as you can see here, at the beginning, the naloxone treatment on the left of this slide, the naloxone treatment in baseline condition was not able to modulate and stimulate LH release, since the antagonist of the opioids was not able to face the very high situation of hyperactive opioidergic tone. But after the treatment integrative, the response was greatly occurring again. And as you can see, from the pink line, you have higher levels of LH. And also the delta, when having the response of LH in comparison to the baseline with a naloxone stimulation test, were very greatly saying that we are blocking the naloxone with a naloxone, the opioidergic system, and improving the release of LH, thanks to the presence of carnitine. So then later we tried to test if probably carnitine was the only substance, or maybe there is something else that might be helpful. So we combined other substances such as not only carnitine, but also arginine and N-acetylcysteine. And remember, such kind of substances, the arginine and the NAC, N-acetylcysteine, are great antioxidants. They are great antioxidants, so they permit the recovery of glutathione inside our cells, which is the most important antioxidant, oxidative agent that our cells have. And you see here that when we tried to solve in these patients the LH release, well, the greater response in terms of LH was in the patients with very low levels of LH. And these are the patients that also had and showed the reduction of cortisol and a little bit the reduction of the amylase. Amylase is an indicator of the lack of energy. The normal LH patients are not responding apparently to such kind of integration. So why? Even though they have functional hypothalamic amenorrhea? Well, the answer is quite easy, is simple, because these patients came to us before the situation was even worse. So before the situation was with very low levels of LH, because the biology was really terribly in difficulty and have blunted at all the gonadotropin release from the hypophysis. So the story comes clearly here that also the response to the GnRH test in these patients was present, very reduced in hypo-LH patients and restored when they have the integrative conditions with carnitine, but not in normal LH patients, because the disaster in terms of the reproduction was not yet so worse as in the hypo patients. Well, when facing all the data of these patients, so this is a complex slide, but I tell you quickly and easily the things. You see, patients with hypo-LH were those where the treatment induced the restoration of the low levels of FT3 to normal levels. And as you can see here inside the green box, a lot of parameters were restored close to the normality in comparison to what is going to be changed in patients with normal LH plasma levels. But these patients were those that had no such negative situations as the hypo-LH. So the integrative approach is really working when things are greatly bad. So the hypo-LH patients are those that are really in difficulty. And also, this is also another complex cartoon, is just to say that a lot of comparison and correlations among hormones are going to be changed, especially in hypo-LH patients, with the treatment. And the restoration of some of these, parameters and correlations are due to the recovery of the biology to be able to work thanks to the integrative compounds, since carnitine is able to induce a better way of working inside of the neurons of the hypothalamus. So again, we have to remember that whenever we have the action of stress, we have to consider that probably is not a matter only of carnitines, but also probably of antioxidative effect. And we have to remember that the only substance relevant to block the ROS and the reactive oxygen substances creation and negative actions is the production and the reactivation of glutathione. So the presence in this integrative approach with carnitines plus NEC and L-arginine was able to probably determine a greater effect thanks to the antioxidative action of these substances. So we have clearly understood that probably the patients should have a better food, a better aspect of the nutrition, but probably we might give some integrative approach with substances that are useful for the biology, so that to face the lack of these substances through the nutrition itself. But today I want to show you another story, and another story that links also to the fact that inside the hypothalamus, we have a specific neurons, the so-called candy neurons, that are sensitive to the positive and to the negative effect. And I remember you, the positive effect feedback is when the low levels of a substance is able to induce the activation of other neurons or other cells, while the negative feedback is the one that occur when a substance is able to block such kind of substance. So I want to show you the experience that we have using in functional hypothalamic amenorrhea a specific integrative approach using or very low estrogens, very biologically low in terms of bioactive estrogens such as estriol, or estradiol in very low levels, hyper low, or in low levels. So again, this is the picture that I have already shown you. So the actions of feedback are played mainly on the candy neurons, and specifically the positive and negative one are played the positive on the AVPV nucleus and the negative one on the arch nucleus. We will play now the action using the positive feedback, mainly so in the AVPV nucleus. So what we know is that the positive and negative feedback is played all along the classic, normal menstrual cycle at the beginning, and then you have the positive one, which is playing a role when you are close to have the peak of LH and FSH. And we have thought a little bit just to use this. And this is just to honor Andrea with a classic picture from a paper which is, let me make the count, from 1978. So almost 40 and over years ago, which is a wonderful idea, where Facchinetti and Andrea played a wonderful exploration using a weak estrogen such as epimestrol, which was able, when administered, to induce a better response in terms of gonadotropins in these patients with functional hypothalamic amenorrhea, improving also the response to the GnRH stimulation test. Well, we decided to test a little bit with a different estrogen, such as estriol. And together with our friends from Poznan, Professor Meczekalski knows very well this paper, we produced the first demonstration that also 2 weeks of priming with very low levels, such as 2 milligrams of estriol, was able to induce the elevation of gonadotropins, such as and mainly LH and also FSH in these patients, with very relatively increase of estradiol, which is more than 20 picograms, which is nothing. But you see here how very low levels we have of estriol at the beginning. And such kind of situations clearly play a role as a feedback, positive feedback inside the control of the hypothalamus. We repeated such kind of experiment, but this time we tried to have this done for 3 months in a row. And you can see here that the elevation of LH is even greater this time. And you see here the response to the GnRH test, how higher is in comparison to the baseline. So we clearly have the demonstration of what? That estriol is probably inducing something inside inside the hypothalamus and probably the pituitary, because inside the hypothalamus we are playing a role since we are priming with estriol something that permits to be more sensitive to the reactivation of the kisspeptin neurons and then of GnRH. But on the other side, from animal studies, it has been demonstrated that the priming was able, with estriol, was able to induce also a greater representation of receptors on the pituitary cells, so that if you increase the amount of GnRH release, you have a greater response from the pituitary, especially from the gonadotropic cells. So we have played a double role in these patients. And you see here how relevant is the significance of the clinical result. So we repeated another experiment using sublingual administration of an alcoholic solution with very low levels of estradiol. And you see again, exactly again in the same way, we got the same result. So we implemented and improved the baseline levels of LH, and we had a greater chance to see the response of LH to the GnRH test. And this means that probably the feedback, the positive feedback, which is played by such very low levels of estriol and estradiol in this case, are able to prime the neurons to improve the activity of the cells. Well, and what about the opioidergic tone? Since we have told you that the stress with the CRH, CTH, the adrenal gland was able to induce, obviously, a greater amount of opioid and transmitters and peptides inside the hypothalamus. Well, again, this time, we see that the naloxone infusion was inducing in baseline conditions a response of LH which is not so high and is a late response. After the priming with these very low levels sublingual administration of estradiol, we got a sort of greater elevation of LH plasma levels. But you see here, the significant response was occurring at least 15-20 minutes before than in baseline conditions. And also cortisol showed a change in the response to the naloxone infusion. So the model here is quite complex, but it might be intuitable. When we are priming with estriol or estradiol the neurons inside the hypothalamus, we are playing a sort of a reactivation of the expression of the receptors for opioidergic as well as for proteic hormones inside the brain, because estrogens in general are the only steroid compounds able to induce the expression of the receptors. And this is rather important, since this permits a greater response of the neurons to whatever is the stimulation, or to the naloxone, or to the GnRH stimulation, when you have to play a role on the receptors of the pituitary cells. And now the very new issues that we have demonstrated and recently sent for publication. This paper is under publication. Well, we have tested the use of galenic preparation of estradiol, oral administration of 0.2 milligrams every day, and we have tested a group quite relevant of well-screened patients with functional hypothalamic amenorrhea, 56, and you see how the administration of this small amount of estradiol in 4 months, 16 weeks, was able to elevate LH, to elevate FT3, to elevate the level of insulin, to reduce the level of cortisol, to improve a little bit, but relevant BMI, and to reduce the levels of allopregnanolone. So the whole group demonstrated that without having any interaction in terms of change lifestyle was able to induce relevant change in terms of neurofunctional activity at the levels of the hypothalamus. And when we discriminate the ones that had hypo-LH levels or normal LH level, well, all the main changes were in the patients with very low levels of LH, and very few changes were occurring in patients with normal LH levels. And when I say normal or hypo-LH, I mean below 3 milli international units or above 3 milli international units. And what is interesting is that the main changes are related to the stressant situations acting inside the brain, since you see how the levels of cortisol are reducing, and this occurred in both groups. But the main changes, such as allopregnanolone, insulin, and FT3, are played and occurring only in patients with hypo-LH levels. So when dealing with these, the whole set of patients are different in terms of hypo or normal LH. You see that there are specific differences among these groups, but one issue which is relevant is that there is no differences in times of amenorrhea. What does this mean? That these patients have, in the average, 1 or 1 year and a half, so up to 18 months of amenorrhea. But the two groups, hypo and normal LH patients, do not differ for such kind of time of amenorrhea. So the levels of LH are not dependent from how many months have occurred of amenorrhea, but mainly probably to the amount of stress that have hit these patients. And also the markers of bone are completely stable and not different in these groups of patients. But the interesting is that when administering this small amount of estradiol, we saw great changes in the hypo-LH patients. You see how many parameters are changing, and these are the parameters that clinically we should have to evaluate, since FT3, insulin, amylase, cortisol, and allopregnanolone are the perfect indicator of the changes that are occurring in the bed situation and how much simple administration of low level of estradiol are able to change when administered for at least 16 weeks. The patients with normal LH are changing not so much. The only things that are changing are the level of TSH. This means that probably thyroid is going to have a change, if not completely clear how, but probably due to the trying to find an equilibrium, since stress is acting also on the synthesis of FT3 in these patients, but greatly also in this group on cortisol. So cortisol is a sort of the soul of the stress in these patients. So again, what we can say, that the changes greatly are still occurring in between the two groups, hypo and the normal LH levels. We are improving, obviously, these endocrine parameters, but the normal LH patients still are more normal than the other ones. And we still need to work on this and probably to push in changing the style life in these patients just to have the best results. But I want to show you these two simple graphs. When considering all together, so hypo and normal patients all together, the whole group, well, see the red line, which is the correlation of cortisol with the LH, and see how the treatment is changing the inclination of the correlation, the green line, after the 16 weeks of treatment. And while the red line was not testing a positive or negative correlation, so no negative correlation, but greatly stability in the terms that cortisol is really affecting LH, whenever you have a small amount of priming with a positive feedback using estradiol, you see again how now the negative correlation between cortisol and LH is really coming out. This means that the system is really regaining the way to face the reactivity to stress. And so whatever is going to reduce cortisol permits the elevation of LH. On the contrary, on the right, you have the correlation of LH and FT3. What does this mean? That during the treatment, you see the red and the green line are almost parallel. There is no great change in terms of correlation between LH and FT3, but this gives clear idea that what is the metabolic activity and actions that is occurring through the thyroid function is really modulating reproduction. Because whenever you have the going down of the FT3, which seems to be a suggestion to save energy, reduces absolutely the levels of LH. And this is still present before and after the treatment. So this is a very, how can you say, insight stabilized system inside our biology. And this protocol is something which is not new. Since 3 years ago, the Pediatric Association, the Pediatric Endocrine Pediatric Association of Europe have stated that such kind of treatment with galenic preparation of 0.2 of estradiol is the treatment to induce the pubertal maturation in patients with delayed puberty and mainly in the Turner syndrome. So just to say, estrogens are relevant, and estrogens are relevant in these patients especially because you know very well, and Professor Meczekalski have shown us this, that might affect the cardiovascular system, the brain, the bone. So we have absolutely to think that we have to act in these patients with lifestyle for sure, but mainly we have to give a signal using probably the beginning with the priming with estradiol, just to let the system to have a start up again of the biology. And obviously, we might use hormone replacement therapy with transdermal estradiol, with a cyclic progesterone. It's better to use molecules that are safe and quite more close to the normality and to the naturality of our biology. And this is relevant to be think, because we have to consider that in many cases, the patient wants to have menstruation, and they promised that they will change, they will be less active with the physical activity, and probably they will improve the eating with the good food and try to have good nutrition, but they want to have menstruation. Well, the choice for the so-called contraception in these patients, just to restore the cyclicity, probably need to be done using all those kind of contraceptives that contain natural estradiol, because this is the substance which is more respective, obviously, in our patients. So the take-home message is that we need to understand better the patients. We might have a good integrative approach, but if we need to have probably a good solution to the hypoestrogenic conditions in these patients, is to start to prime the biology with low level of estrogens, starting with estriol, maybe with estradiol, which is now a good idea just to face and to use it. And if we need to have contraception, at least to restore immediately or a sort of control of the menstruation and the bleeding in these patients, we need to have contraceptive with natural estrogens. Thank you very much.
Thank you very much, Alessandro, for that fantastic presentation, who together with that of Blazej Meczekalski make a whole picture of hypothalamic amenorrhea and how to face and how to treat also in the modern time. I would like to have also the presence of Biagio, and we will go to the question and answer. First of all, I would like to thank Mirfat Al-Bashir to be with us and to answer to him that our webinar will be recorded and will be online for all of those of you who were registered. Then we have a question from Murad Saif. He tells, in my practice, we see a good number of patients when FSH and LH are not very low, for example, 5 to 8. And many clinicians will consider these as normal. I therefore use the term not elevated to differentiate to really depleted syndrome. Then do you believe that 5 to 8 in comparison to the lower concentration should define the difference? Blazej?
Yes, thank you for the question. We just talked about it. According to our study together with Alessandro, we consider that patients with low LH are patients with LH lower than 3, with normal LH higher than 3. We can use the term normal LH, although the big group of the patient from my clinical practice has really very low level of LH. But generally, these patients are characterized by hypogonadotropic hypogonadism in comparison to hypergonadotropic hypogonadism, which is typical for premature ovarian insufficiency.
I agree.
I'm sorry.
I agree.
Oh, we have also a question for you from Gabriela Ayala. Dear Alessandro Hughes from Ecuador, could you please explain deeper why we consider amylase a marker of low energy?
This is quite interesting, since we have spent a lot of time just to better understand such kind of strange enzyme, which is just going all around our blood. Well, amylase is produced by the pancreas and is a sort of hunter inside our biology, a hunter of the oligosaccharides. So the small molecules such as maltose, which are created by the combination of two molecules of glucose. Well, such amylase is hyperproduced whenever these patients have a very low introduction of food, which after digestion do not release great amount of glucose itself or of maltose. Well, amylase is a sort of indicator that suggests greatly how is the metabolic equilibrium in these patients. Just to give you an example, whenever we have patients that do not menstruate, the issues that we are just saying in these patients and the hormones are LH, just to see how much low or normal is, but mainly FT3, insulin, and amylase. Low level of FT3 is an indication that the system has very low energy to spend to maintain the heating of the body. The low level of insulin means that the glucose is not so high in the blood, so there is no need of the use of insulin just to induce the upload of glucose inside the cells. And amylase, if high, is an indication that after the absorption inside the intestine, we do not have enough small peptides or oligosaccharides that are circulating in the blood. So whenever you have these three evaluations, you know whatever is the situation of the lady in front of you, you know the equilibrium between reproduction and metabolism.
Thank you, Alessandro. And then, Blazej, we have a question from Gultajan Babajanova. She asks, it is possible to predict the development of secondary amenorrhea in adolescents?
Good and important clinical question. We don't have the specific meter to recognize the problem, but in my opinion, as we just talked, there are specific stimuli like excessive stress, excessive exercise, or weight loss. Therefore, in my opinion, young women should be aware about the situation that, for instance, excessive exercise or excessive stress can cause the problem. And we as the doctor, like gynecologists and endocrinologists, should give this message that such behavior can be threatened by hypothalamic amenorrhea, and it should be kind of the health education among young women, because we know that they have different behavior. They can, practice sport every day, run 15 kilometers or 20 kilometers, or can go to specifically very restrictive diet. Therefore, in my opinion, education is very important.
Thank you. And then, Alessandro, we have a question from Franca Fruzzetti. I thank Franca Fruzzetti for her presence with us. And she asked a very interesting point. Some psychologists don't agree about the use of hormonal therapy in girls with amenorrhea, anorexia nervosa related. Do you agree?
Well, I agree in the use of very low level of estrogens, because the choice of contraception might be something that might occur if we have to face specific issues in these patients, such as osteopenia or osteoporosis. The data that we have using very low levels of estradiol have clearly demonstrated that we are able to interfere, and this is a very new issue, to interfere in a positive way on the CTX substance, which is the indicator of the degradation of the bone. So the fact that we might use with no great influence on other compounds with very low level of estradiol might be a good strategy, just to let the biology little by little gain a little bit the control of the neuroendocrine modulation of the reproduction. Since the results using low level of estradiol have been got in almost 70% of the patients, and in both groups, the hypo LH and the normal LH, within the 16 weeks, we got a menstrual bleeding, which cannot be said as a real menstruation, but is something which is really stating that the equilibrium probably and the blockade has been changed a lot.
Thank you, Alessandro. And then I would like from Biagio, Murad Saif, thank you for your views. And please, the use of combined oral contraceptive in early onset functional hypothalamic amenorrhea, particularly for long term, may not allow full development of the uterus or angiogenesis. Subsequent, we encounter difficulty achieving good outcome later when ovulation induction or assisted reproduction technology are needed. What is your believing about that?
Yes, exactly. As we mentioned, but at first, great congratulations for Alessandro for wonderful lecture, a view on the treatment of functional hypothalamic amenorrhea. And we generally agree that the use of combined oral contraceptives should not be considered in this group of the patient, mainly apart from the contraceptive with the ingredient as the natural estrogen, or maybe in the future estetrol. But we should use the natural estrogen, or as Alessandro mentioned, the estriol or estrogens in the very low doses.
Thank you so much. And then now, Cinzia Gentile, Alessandro, she have a question who start in summary. She said, for patients with hypothalamic amenorrhea lasting longer than 24 months, can I choose between a therapy using a drug with natural estradiol or a normal replacement therapy based on the patient's contraceptive needs?
So I can tell you what I might think about this. And this is that at the beginning, probably we might spend some weeks, which is 6 up to 10 weeks, just giving a priming with low dose estradiol. This is my idea. And as a second effort, we might discuss with the patient or using transdermal estrogens, which is probably the most known and diffused strategy just to face the hypoestrogenic conditions in these patients, and later on giving some progesterone just to reinduce a sort of maturation of the axis. But in some cases, such kind of treatment by this young lady is seen as, hey, I am getting like a menopausal woman. So I do not want to be treated as a menopausal woman. So the strategy that I have already mentioned of the use of the contraceptive with natural estradiol might be a good alternative and solution in these patients, because you know, not all of the young ladies are able to, how to say, face the fact of having a patch or having a gel every day and having progesterone just for 2 weeks in a month. So this creates a little bit of discomfort. So you have to discuss a little bit on the patients. But the strategy is to reintroduce in these patients estradiol, because they need estradiol after at least 18 up to 24 months of no menstruation.
Thank you. Then we are now approaching to the end. Then we have now a question, Biasio, from Anankina Alia. Thank you very much for the interesting presentation. I would also to thank both of you from Sergio Murillo Stephens and Mary O'Flynn. They make a huge compliment. Then Anankina, she asked, could you please tell me whether you prescribe pharmacological therapy to all patients diagnosed with functional hypothalamic amenorrhea right away, or in some cases do you start with psychotherapy and lifestyle modification?
I think that very good point. At first, as I mentioned in my lecture, and also Alessandro in take-home message slide, in my opinion, the lifestyle modification are crucial or critical, because we need to withdraw the stimuli, or limit at least the stimuli which was responsible for appearance of functional hypothalamic amenorrhea. In other words, with the weight loss patient, we need to encourage the patient to got weight, to increase the weight. In the patient with excessive exercise, we need to at least encourage the patient to limit the physical activity in the sense of the amount or frequency. And generally, in my opinion, the use of therapy in the sense of the estrogen therapy is important, because with the use of this therapy, we can prevent the long-term consequences in the sense of the negative impact on the cardiovascular system, the bones, and also the function of central nervous system.
Thank you, Blazej. And now, Alessandro, an interesting question from Linda Americ. What happens in perimenopause?
This is a great question. This is a great question because every time that we have a functional hypothalamic amenorrhea, we have to think a little bit not only for the reproductive problems, let's say so, but also to what is the future of these girls. So the greater and the longer is the hypoestrogenic conditions and the longer is the amenorrheic conditions, we deeply impact in a negative way on the peak of the bone mass. And this is a sort of a reduction of the amount of bones, of bone mass that we might have at the moment of menopause. So we will reach the peak of the bone mass within the 23, 25 years of age. And that's the moment in which probably most of the patients are hit by functional hypothalamic amenorrhea. So they lose a part of the mass of bones since the hypoestrogenic conditions stop the evolution of the bones. So it's rather important for us to save such aspect, because these for sure will be women in which there will be osteopenia and osteoporosis years before than the expected, or just at the beginning of menopause, when they had maybe just 1 year of menopause, no menstruation, and the DEXA gives you the response of being with -2 or -2.3 of bone in terms of bone mass, which is the heritage of what happened when they were young.
Thank you. Dear friend, it's already 90 minutes of webinar, something more. I would like to thank all of you. It's a fantastic topic in our daily practice. And I would like to thank you for Alessandro and Blazej for the approach that you have given to all of us, starting from the vision that this is something who can naturally happen to save women when they are in stressful situation, by the fact that the pregnancy makes them even more fragile. But also we have to restore that one, because hormonal function is totally protecting the female body and maintaining that one. Then now, dear friends, thank you very much of being with us. I would like to thank you again, all our participants, and to tell you that the European Society of Gynecology will have Tuesday, 14th of April, a new webinar, which will be chaired by Professor Tommaso Simoncini, where Professor Günther No, Professor Uzehir Kolkan, and Dr. Laurent Deloncher will be present. The chairman will be also Angelos Danilidis on urogynecology, novel approach for pelvic floor disorders. I thank all of you, and I suggest to join us. And in addition to that, I would like to remember that the 17th Congress of the European Society of Gynecology will be 1 year from now in Porto, in Portugal, in the fantastic city, from the 17th to 20 March 2027. Enjoy that one. Come with us and present your paper, present your title to the Congress. You will be strongly excited by the participation to the 17th European Congress of the Society of European Gynecology. Thank you, dear friends. Enjoy the time, and see you soon.
Thank you.
Thank you.
Ciao, ciao, ciao.
Ciao, Alessandro. Ciao, ciao. Thank you. It was beautiful.